Okay, well, good afternoon, and got some good numbers to share with you again today. So we'll be covering those as we look at what happened over the past week. It's Thursday, and some weekly trends on some direction there, and then what are we looking at on the week ahead. We had some press aspects related to the imminent release of our tracking app that we're hoping to bring out soon, and the Premier made those announcements along with the Minister of Health. And as well, we have looking at the number of health units or areas that today will be, tonight basically, moving to the 7 of the 10, moving from stage 1 to 2. And the other 3, the final 3, we are in reviewing and having consultation with their medical officers of health as we seek to look at how they might be able to progress along with the rest to stage 2. So looking at today's highlights, in that we have a total of 32,917 confirmed cases of COVID-19. So the increase is 173, and that's our first time under 180 for quite a while. The last time we're at below 180 was on March the 16th, believe it or not. And so we are continually coming down, and that's encouraging to look at there, because when you look at the new cases, well, a lot of them are around the GTA. Those numbers are down as well. Toronto with only 70, Peel with 27, and York with 14. So we can see that a lot of the health units have number of cases have had none again, and many of them have between 6 and 10 cases a day. Small numbers, well within their ability to do the contact tracing. And 16 of the health units had no cases again, and so that's encouraging. As well, lots of people continue to recover. We had 220 Ontarians recovering, so it's another day again with more recovering than new cases being declared, and so that we have 28,004 who have recovered. That's 85.1% of our cases, and that's also an encouraging number in that one. Currently, we have 351 people in hospital. That's a reduction of minus 32, another good number. The ICU is down as well by 8, down to 84, and those in the ICU on ventilator down by 5 to 60. So all positive directions. As well, deaths still do occur, but today we only had 3, and that's the lowest number we've had in a long time. And while still being unfortunate, it's good to see that the number is dropping off, and it'd be nice to see that even down further for a total of 2,553 deaths accrued thus far in Ontario since January. So there were some weekly trends. Generally, overall, it was consistent before. We have moved steadily down. Our R0, that's the transmission rate number, has been decreasing. We've moved now down below provincially, below 0.9, and that's encouraging, heading somewhat at moments down to 0.7, and so we're watching that very carefully. Our ratio of males to females over the last week, as compared to our early part of the outbreak, they tend to be going back and forth, sometimes males more than females, but generally lately it's been more males than females. Not by a huge amount, but that's just the more recent trends. And of course, our cases are in younger populations, and our numbers in the over 80 and the over 70 has dropped off. So as a percentage-wise, we see more in the 20 to 39 age group, but that's a higher percent of a smaller number, looking at the 173 that we have today. And so our testing also, again, well over 20,000. We had 25,278 submitted yesterday. Our percent positivity rate has dropped again, back down to 1.1. Once earlier in the week, we got down to 1%. We'd like to get that down to 1% or below that if we can. And there's a lot of lab tests coming in. So every day we've been over 20,000. We didn't have even our weekend dip in that. And these are big numbers. They're really testing high, but we're getting a lot of results done. And we're really trying to assess anyone possible who might have any signs or symptoms, risk exposure, either through actual known contact or unknown or suspected, gets tested, because we want to, I guess, in a way, beat the bushes and find as many cases as we can to make sure that our numbers, when we feel 173, we know it's 173 in that regard. We still have a number of investigations and outbreaks undergoing, and that's encouraging in one sense. It's discouraging that there's outbreaks in these settings. Some are work-related, some are more institutional-related. Our numbers in the long-term care homes keep coming down, dropping down to the low 60s at this time. And as I said, the deaths are dropping down, as well as the cases in staff and residents. That's coming down as well. And the same as the numbers in our retirement homes continue to drop down and become low, and some of our congregate settings. Nevertheless, we keep looking at those and keep trying to determine any outbreaks and to address them as quickly as we can. Some are now in workplaces, various types of institutions and companies, and we're trying to identify those and test all their staff in those locations to ascertain if there's some unknown cases we didn't see in the outbreak setting. Thus far, in some of our other testings, in some of our asymptomatic testing, those results continue to remain very low, and that's encouraging as well, but we haven't completed that process at this time. So in light of that, as I said, the week has been one of steadily staying down below 200, keeping that in that direction, our lab testing volumes staying up, our positivity rate going down, all of the other indices in healthcare settings and that all coming down, our number of the health units going to lower numbers, getting to a state where they can move to stage 2, 7 more tonight, midnight tonight, and we hope the final 3 will be following shortly as their numbers have continued to improve and reduce those in a very consistent way, and we hope over the next few days that would be even further affirmed, and thus making it clear that they could move to stage 2 along with the rest of the province. So that's the general update of materials. I know you've had some technical briefings and other things, but now I'm going to turn it over to the media for more questions. So over to them.
We'll go to the phone lines. Just a reminder, 1 question, 1 follow-up. Over to the first question.
First question comes from Antonella Artuso from the Toronto Sun. Please go ahead.
Thank you. Hello, doctors. I wanted to ask if you're aware of any cases in Ontario where someone contracted COVID-19 and then got it again. And what is your advice to people who have had it? Should they act as if they have immunity, or should they assume that they could get it again?
Okay. Am I aware? The answer is no. I can ask our specialists if they've heard of any. The challenge that you're asking there, and we're trying to clarify that, is, and that's why we say when you get a test result done, it tells you that they have found some of the RNA fragments of the virus in your nasopharyngeal passage. It may be that they're just there and you didn't actually acquire the infection to get a viral blood infection, of viremia is the word, and mount immunity, but you may have. And so when some people get these so-called second cases, you're following a test that doesn't tell you if you got a full blood infection or you just had it present in your nasopharyngeal passage. That's why we're looking to have the addition in the near future, and I know our federal counterparts, and Dr. Yaffe's on the table right now discussing things with the Federal Provincial Territorial table, and they're looking at the whole use of serology. That's looking for levels of immunity and how that might be utilized and undertaken to ascertain did someone have really evidence of a legitimate infection in the past and has acquired immunity in that regard. So I think a positive test in itself, I wouldn't say can be conclusive that you have immunity. There's a good chance you might. I think when we get that matched up with serology, we'd have a better indication, but we want to make sure that our serological test is one we can be confident in, that would, if we're going to say that you have immunity, that we are assured that you do truly have that, and we can advise you accordingly.
Follow-up?
Thank you. Yes, thank you. The City of Toronto had reported a milestone, its 1,000th death today. And I'm wondering if you can talk a little bit about what you're seeing in the City of Toronto in terms of COVID-19, where you think the problem is. Is it largely a workplace issue? Can you provide any detail, especially as it's been held back from stage 2?
Well, they had 70 today, and that's one of the lowest ones we've seen in Toronto on a daily basis in a long time. I did have some discussions with Dr. Davila on that and asked were these mostly outbreak related, and she said no, in the recent data, no, they tend to be sporadic around different parts of the city. So she was reluctant to ascribe the cases mostly to outbreaks. There are some, not the majority in her mind. So, and as far as any geospatial placement of those, that has not yet been, at least in the recent days, has been updated. So I'll be waiting for some more direction or advice from Toronto Public Health of how they're assessing their situation as their epidemic curve is coming down, and where they're seeing the sporadic cases remaining that are showing up in that, because where they live is not exactly maybe where they contacted or contracted the virus from. So there's more questions to be answered, and as you get these smaller numbers, you can dissect them a little bit better and segment the data, and we might get some more answers from Toronto Public Health.
Next question.
Next question comes from John McGrath from TVO. Please go ahead.
Good afternoon, Doctor. The Premier was asked today about what powers the Cabinet will retain after the state of emergency ends formally. And I was wondering, I mean, you and other local public health officers around the province continue to have powers under the Health Promotion and Protection Act separate from the state of emergency. And I'm wondering if you are planning either yourself or directing local public health officers to use those powers in different ways after the state of emergency ends.
It's a good question. We, before, as you remember, in all of February, the early part of March, we were using mostly the powers and authority of the local medical officers of health. I did issue some directives under my authority as the Chief Medical Officer of Health, and we had some under the Minister of Health. Those stay in place outside. When you implement the Emergency Act, other powers and things come into state during that time. As the Premier said, when you lift that, things that are put in place, some of the orders, they can be renewed in that on an ongoing basis, but the same authority under new ones and that would be held differently, and it maybe revert back to the normal powers and authority within the government, either through legislature or through powers of the Minister of Health has, or myself, or local medical officers. So those will stay intact as per the legislation.
Follow-up?
But specifically, do you have any idea how those? Do you have any plans to use those powers currently?
Well, some of the directives I have are still out there. You just heard about the ones related to visitation and the long-term care facilities, the ones related to personal protective equipment. So as a CMOH, I do have those authority to write directives to institutions and healthcare facilities. So we have an array of different ones that we could use with the proper trigger points and necessary requirements to put them in place, and proper communication, etc. So those have been there. They are still in place, and we'll continue to use them if and when we need them in order to facilitate an ongoing effective management of the COVID-19 situation.
Just a reminder to join the queue if you have any questions. Otherwise, this will be the last question.
Last question comes from Sean Jeffords from the Canadian Press. Please go ahead.
Good afternoon, Dr. Williams. Just wanted to follow up with you with some information that was passed on in the technical briefing, and Minister Elliott touched upon it, the fact that fax machines are still really widely used in public health and the health system, and that the testing results and tracking of COVID cases are being transmitted over fax. It seems like a very inefficient and dated way to go about this, and I'm wondering, has it hampered our ability to act quickly on tracing and case contact to this point?
Well, as the minister said, it's a bit surprising that we still have to rely on faxes. So those are still in place. Some physicians' offices still prefer to have that. Laboratory tests, instead of having to enter it into a computer, if you do not have that system in place, it's easier just to scan and fax it and send it off. And there's some are still doing that. The question is, if you have robust laboratory systems with digital systems in place, that we call it the OLIS, the Ontario Laboratory Information System, if that links automatically into our public health system, so you don't have to take the things out of there, re-enter it all back over again, that of course would expedite the whole system. So as Minister Elliott commented in our briefing today, that kind of direct connectivity with our new Salesforce type technology will help to facilitate a much more rapid uptake in there, and of course may eliminate some lost files or records or some errors in re-entering again. So these are all positive things, and one that we've been looking for a while, and hopefully this will be a good step forward and continue to utilize technology in a way that is effective, efficient, respecting privacy, and only but helps in expeditiously dealing with COVID-19 in that regard. So I wouldn't mind seeing fax machines go out. I was around when they first came in, but I think their time has played out, and we now need to move on to other technology.
Follow-up?
On another topic, Dr. Williams, the minister alluded to a new testing strategy coming soon for the migrant worker population in the province, and the fact that there have been problems getting workers tested, and that some sort of a hybrid system is perhaps coming with mobile units and stationary units for testing. I'm wondering if you can shed any further light on this plan and what you think is required to help track cases of COVID-19 amongst migrant workers and really control the spread.
So we're having a number of meetings in that, and we're following up with many different sectors involved in this: the local health unit, the industry, the Ministry of Agriculture, Food and Rural Affairs, as well as Ministry of Labor and their sector, as well as our federal counterparts, as we understand the various aspects and segments of the farm industry in those sectors, deal with produce and a number of other materials, greenhouses, etc. So there's a wide variety of different farm settings. They use a lot of seasonal workers, as you've heard, and a number of them come from outside the country, as we carried out a process under federal regulation for quarantine. But now we're finding there's a mix of other workers in there, and some come from local, from within Canada, and different backgrounds. So then we're trying to say, how do we do that test in a way that would assist in any outbreak management, at the same time would help us to assess any risk that could be coming into that community, because a lot of the workers in these settings not only work at the place and they don't commute home in the afternoon, they live in the place, and there's various living situations and conditions as well. So the more we get to understand that whole setting, the better we can be at putting against hybrid models or methods to try and deal with it in a way that is effective, respecting the privacy, understand the limitations of the industry and what they can or can't do. But the main thing is to assure the safety of the workers, and especially we invested so much in our initial model of the migrant workers coming in who spent 2 weeks in quarantine, and we have, by our data so far in testing, we've assessed that the infection and the outbreaks is not coming from that group. It's coming from new ones that came in from Ontario that have been in Ontario, and we have come off of a period of higher rates, and we're getting down to lower cases now. So one should help the other to abate, but then we still need to do a lot of assertive testing to make sure we're not missing the mark on this and dealing with ongoing infections within this group, because some actually do move from farm to farm. So there's a number of things that we're discussing with all our counterparts in the ministry and with our federal counterparts as well. So we hope to get this one wrestled to the ground, and for the protection and safety of the workers, and of course for the ongoing value of the industry.
We have one more question in, so this will be the last question.
The last question comes from Cynthia Mulligan from City News. Please go ahead.
Hello, doctor. A couple questions for you. The first one about the new data system. And I know that the current one that you've been working with is 15 years old. It's been called antiquated. And I've heard many times over these news conferences that it's been difficult to get the data quickly and have it all processed at the same time. How big of a hindrance has this old data system been to you?
So the old system, the Integrated Public Health Information System, and I do remember when it was brought in, and it was far better than the previous one. That was even more cumbersome, just because the amount of data you have to put and enter, and the the technology, any of these things that over a period of time, software, usually about 5 to 10 years, has already had a number of patchworks done on it to make it work and functional. So you can see it becomes more and more slow movement in the ability, especially you're entering 5 or 10 cases, but if you have 200 to 300 to enter in a short period, that slows you down considerably, and the technology has limitations because it's built on an older frame. The newer one that they're bringing in is a much more versatile. Of course, as people today, and it's technology in these days, and it's 5 to 7 years old, it's already outdated. And so this would only but help much faster, much quicker, a lot more so-called artificial intelligence applications. It's connectivity directly with the laboratory system, so it has many promising aspects to bring in there as we go forward. So a new system, a quicker system, and one that can do all the job as the previous one, even in a more effective and efficient way, would certainly be applauded by the public health staff who have to do the work of entering and utilizing it. But at the same time, as far as the case contact management, a lot of our case contact managers out there will be still working with their notes and materials much like they do before they entered in. So it hasn't slowed them down in that regard, but it does slow down with the central data entry, which means that you're wondering why we have these blips and changes in the data because of the entry system is a challenge. So from a central data recording, it's been more of a challenge for us to try and give you the data as forthright and as timely as we want to. But that, I don't think, has slowed down the public health investigation. The main thing that slowed them down is the immense load of the cases and the difficulty of people trying to recall their history in the previous 7 to 10 days, which, as we alluded to, is not an easy thing in our briefing earlier. And we're going to help them with the app, may actually assist them in that and help them to understand some areas of potential high contact they had been exposed to in the previous 2 weeks.
Follow-up, this is the last question.
Thank you. And for my follow-up, sorry, are you hearing feedback? I'm not sure why that's happening.
I'm not here.
Can you hear me okay?
Yeah, I'm here. You're clear here, Cynthia.
Okay, wonderful. Thank you. For my follow-up, I know I've asked you about this before, but I'm wondering why there isn't a mandatory mask policy. Growing chorus of doctors who are asking you to recommend making masks mandatory in stores. And there's growing research that suggests that that is effective. So at this point, why not make masks mandatory inside stores?
So we have progressively moved forward on that one there, where as we get out more into the community and as the province opens up and more retailers are there, and not all store facilities have the same layout and may have more challenge with keeping people physically separated. So we have been strongly recommending the use of a fabric or a cloth mask covering in that, and more places, especially with dense populations, are going towards asking it become a stronger recommendation, and local medical officers of health, and some have already issued some orders in that regard, they have made it mandatory in their respective jurisdictions. So while we understand that there may be reasons that an individual may be physically or for some reason not able to wear one or may have not been able to acquire one, you have to put those things in place too. So you want to make sure that if they're willing, that they can be able to do so and you supply it or make sure they have one. At the same time, there's some outer areas that may say it's not as that important because the number of people in these facilities is very much smaller. So part of that is respecting the knowledge base of the local medical officer of health and the municipal structures and bylaw officers, that they can ramp up our recommendations and put them in the place of orders in that regard, because what might apply in a transit system may be different than a retail setting, which may be different than a recreational setting. So as this evolves, we're going to see some variations in that, and I think a lot more are going to probably require mandatory wearing of it as the numbers of people out and around increases.
Thanks, everyone.